Hello and good morning, everyone, and welcome to one more lecture about common neonatal problems. So, like in the previous lecture, what we were covering was I told you about different conditions. Uh, Joined us, we had done intraventricular hemorrhage or intracranial hemorrhage, we had done, and many other conditions we had already covered. So, uh, in this one, of course, I will try to wind up all the rest of the common neonatal problems. There is something called as preterm brain injury, like in the babies who are preterm, uh, hemorrhage can occur in the brain around 25% of what you can say very low birth weight infants, and that we have already discussed in intraventricular hemorrhage. And just I want to uh, I want to mention this thing that some of the conditions, they have lifelong implications or effects on the babies or on the people. Yeah, some of the conditions or neonatal conditions don't have a lifelong implications. Yesterday, or in the last lecture, connectors, for example, if it is going to damage the basal ganglia or the brain, of course, the condition have the lifelong effect on that baby. Same with what you can say preterm brain injury or intraventricular hemorrhage. So, starting with one more topic that is called as necrotizing enterocolitis. So, as the name shows, like necrotizing, like necrosis is there, and enterocolitis, there is inflammation of the intestines. So, it's a very serious condition. It's a very serious condition, and how we can define that? It is intestinal inflammation, enterocolitis. Okay, intestinal inflammation is there, associated with uh, focal or diffuse ulceration and necrosis. So it could be focal, it could be diffuse, and there is ulceration, there is necrosis, and mostly it affects the uh, terminal ileum or and colon. Okay, so this is the most common location, that it can occur. It can affect. Necrotizing enterocolitis, it's a serious injury and it's mainly affect preterm infants in the first few weeks of life, and it is associated with secondary bacterial invasion of the ischemic bowel walls. Okay, so there is, of course, ischemia, which will lead to ulceration and necrosis and inflammation as well. Um, so it affects 1 to 5% of preterm babies. Okay, so not so uncommon, you can say, preterm babies. Um, Not all the preterm babies, but those who are admitted to neonatal ICU. Okay, so the exact mechanism is not known, but what is the theory behind this thing is, um, like when these preterm babies, they are feeded on milk and especially cow milk. So what happened is, like, there is mucosal damage, and there, due to that mucosal damage, there is bacterial overgrowth in that area, which will lead to bowel necrosis, gangrene, or perforation. Okay, so remember, preterm babies who preterm babies who are cow milk fed, okay, who are on cow milk, by the way, okay. What happens is like they have increased chances of developing this condition, okay. Why? Because they found like the infants who are taking breast milk, they are having less chances of having this condition. So cow milk babies, they have more chances, okay. So what happened is simply uh, it can lead to mucosal damage, okay, which will lead to bacterial overgrowth. This is a postulated theory, overgrowth, okay, and which will lead to like the consequences. Of course, like it could be necrosis of the bowel wall, it could be gangrene formation, it could be perforation, okay, all those things can occur in this one. And what happened, like of course the babies, they don't tolerate the feeds anymore, and they can develop vomiting, they can develop bile and vomiting, okay, and their abdomen become distended, and their stools become sometimes contain fresh blood. Why? Because there is necrosis and there is gangrene, or there is perforation. So of course, like their stools can become what you can say full of blood, okay. So like this is the presentation of these babies who get this condition, okay. So we can add this point, by the way, here. uh, Risk factors is again prematurity, as well as babies who have undergone shock, because shock lead to less blood supply to all over the body, especially the gut, which is affected in this case, hyperosmolar feeds, okay, as well as breast milk is protective, and cow milk or sepsis are the risk factors, okay, are the risk factors in these babies. So now I will talk about few of the clinical features, and then of course like we will talk about what you can say the other things which what we can do in these babies. What happens in these babies is like usually uh, usually they present around 2 to 3 weeks of age, okay. And how they present, like as well, I was telling you, they have distended abdomen, okay. uh, they vomiting is there, sometimes bile stained, okay. What happened is like their stools can be can have blood, or bloody stools can be there, right. uh, what else, like of course like they cannot tolerate their feed, so feeding intolerance is there, and ultimately of course like they have what you can say paralysis of their gut movements, or a paralytic ileus, or they have diminished. When we examine them, we will found that they have diminished bowel sounds, okay. So this is like all the presentations, and the complication of this condition is what, like is perforation, right. So remember, whenever there is perforation, which will change the dimension of the condition from medical to surgical side. Of course, perforation will lead to peritonitis, okay, and peritonitis, of course, can lead to sepsis or shock or disseminated intravascular coagulation. So, too many serious implications of this condition, right? And like very serious type of condition. So simply, like like the infants may rapidly become shocked and require artificial ventilation because of abdominal distension and pain, when there is abdominal distension and pain, of course the infants, they cannot breathe properly, so sometimes we have to put them on artificial ventilation even. So basically what we do is like to investigate them, of course, like what we do is we do abdominal x-ray. Okay. And in abdominal x-ray, the hallmark of this condition is called as pneumonitis, okay, or the air, okay, intestinalis, okay. So pneumonitis intestinalis is simply um, intramural air, or air inside the intestines, you can say, right? You will see, if you will write what you can say on the Google, and if you will write, necrotizing enterocolitis X-ray, you will found that you will found like X-rays, especially on the right side of their abdomen, like where there is ileum or ileocecal junction is there, you will found that they have like too much air in their intestines. Okay, so that is called as pneumonitis intestinalis. So we can do this thing, intramural air. This is the hallmark of necrotizing enterocolitis. Okay, so you will found, for example, if there is perforation, so you can found free air in the abdomen. You can say air under diaphragm. Okay, and all these things. And rest is like all the what you can say, the regular investigation which we do, like in most of the conditions, like CBC you can do, ESR and CRP you can do, right? And of course, like in CBC, you will found that maybe the platelets will be high or low. Platelets will be low, and of course, like we can do ABGs, right? Because there is breathing difficulties as well. So maybe we can found um, acidosis. Okay. So also it's a very serious condition. We can go for lactate levels. If the lactate level is high, so of course it shows like bad prognosis. We can go for blood culture, okay, to check like what kind of antibacterial we should give to the patient. And you can also go for electrolytes, because it is a condition in which there is vomiting is going on, and there is perforation can be there. So of course, like we can do all these things. So for example, in electrolytes you can get hyponatremia. Of course, like when you will do ABGs, you will find that they have hypoxia as well as hypercapnia. When you will check the lactate, they will be high. When, like, of course, like depending on the condition of the baby, right? If the baby condition is bad, so of course, like they can lead to this thing. So X-ray we can do all these investigations, and if the perforation is there, of course, the treatment is surgical, right? So how to treat this condition? Okay, the treatment of the patients who have necrotizing enterocolitis is like, we of course, like, remember, like even in surgery, whenever someone is developing infection in the intestines and there is risk of perforation, the first thing we do is always putting the patient nothing per oral, right? So of course, like we must stop oral feeding in these babies. Okay, so at least for 7 to 10 days, because we have to give the GIT or intestines to the time to heal up. Okay, so nothing per oral for 7 to 10 days, and then we go for of course, like when they are not taking anything by mouth, so you have to give them IV fluids. Okay, resuscitation should be done. So like this will help you in surgery as well. Like all the surgical conditions, they have the same type of treatment. Okay, um, all the conditions, surgical conditions, whenever it is related to gut, so we always do the same thing. Okay, nothing per oral, and then we give them IV fluid resuscitation. uh, we don't want any secretions to pass through the intestine, so we will pass a nasogastric tube to suck all the gastric secretions, right? And of course, they need proteins, they need carbohydrates, they need fat. So how we can provide them total parenteral nutrition? Okay, so we can give them provide them everything parenterally. Like, of course, in general surgery, we have discussed all these things, right? What is TPN and total parenteral nutrition and everything. So, see, this all measures are taken in all the surgical patients simply, whatever we are talking about until now. Whenever there is anything related with the intestines, we always stop all the uh, oral feed to uh, we the stop all the oral feed and to give rest to the intestines and pass NG tube, give IV fluids, and as well as give TPN, total parenteral nutrition. Of course, like there is a bacterial infection as well, so we have to give antibiotics, okay, to these patients. So in neonatal age, guys, like mostly we try to give like a broad spectrum or like covering all the gram positive, gram negatives as well as the anaerobes. So simply, uh, we can give them usually in the hospitals. What I have seen even all the neonates, whenever they have infection, so what they do is like they put them on ampicillin for gram positives, gentacin or gentamicin, whatever you gentacin or gentamicin, whatever, like, of course it's same names, for gram negatives, as well as we put them on metronidazole, okay, which is to cover the anaerobes. So we put them on these antibiotics, okay, of course, uh, like uh, like to protect them or to treat the infection simply. And when we are started this treatment, so what is the next thing you will be doing is to perform serial abdominal x-rays, just to check like either the patient is going towards any perforation or what is the condition of the intestines, okay. So why? Because remember, guys, whenever there is perforation in the abdomen, uh, not even babies, like even in the adults, the mortality increases too much high, because that's a serious condition anyways, right? So of course, like if someone have uh, got perforation, so of course, like, what is the treatment? The treatment is, of course, surgery, right? So surgery, when they perform surgery, what they do is they cut any dead tissue, whatever they found, okay, and they try to fix everything. So this is the treatment, and uh, it is a serious condition. It have a mortality of around 20%, but if there is perforation, the mortality goes up to 40%. Uh, as I told you, many of the babies, because they cannot breathe properly because of abdominal distension and pain in the abdomen, many of them, they need ventilatory support as well. Okay, ventilatory support as well is needed. So, like, this is the treatment of this necrotizing enterocolitis. So you can see the X-rays. Like I can show you one X-ray over here. Like, this is an X-ray of of what you can say, of a neonate. Diagram of characteristic feature of necrotizing enterocolitis on abdominal X-ray. You can see this one. Okay. You can see this one. These are distended loops, bowel loops. Okay, this one, this one, this one, this one, and this is like intramural air. Okay, and air in portal tract, as well as air under the diaphragm, which shows like bowel perforation. So this is like one of the X-ray. Okay, for the babies who have necrotizing enterocolitis. Okay, uh, so yesterday, like, one of the lecture I make, like, I talk about retinopathy of prematurity. So, well, I have already discussed that, like, that is a condition in which the blood vessels at the junction of vascular and non-vascularized retina, there is vascular proliferation, and what happened is, like, which leads to retinal detachment or fibrosis and blindness. I already talked about that. Okay, So after necrotizing enterocolitis, there is some respiratory conditions which we have to cover. Okay, and the most important respiratory condition which we are going to cover is um, bronchopulmonary dysplasia. Okay, bronchopulmonary dysplasia. Okay, so okay, bronchopulmonary dysplasia. Okay, so what is bronchopulmonary dysplasia, guys? Simply, uh, it's a chronic type of condition, you can say. Okay, it's a chronic type of condition, which in which like the patients, okay, who get this thing, uh, what happens is like they have permanent damage to the lungs. Okay, uh, what happens in these patients is like it have more like you can say uh, a different type of definition. Uh, okay, first of all, I tell you this is also called as chronic lung disease. Okay, as I told you, it's a chronic type of condition. The other name is chronic lung disease. So it have more like of you can say uh, a definition which requires a lot of days to diagnose that. So clinically, or you can say a clinical type of definition, uh, it is defined as when the oxygen requirement, okay, requirement uh, is for 28 days uh, plus persistent, you can say, need for oxygen, persistent need for oxygen or ventilatory support at 36 weeks of corrected gestational age. So, see, it's a clinical type of definition. Basically, the infants who need oxygen, uh, like provided they are born at 36 weeks of age, okay, and they are requiring oxygen for more than 20 days, okay, so for more than 20 days, sorry, I forget to put that thing here. So when they require oxygen for more than 28 days, okay, uh, either oxygen or ventilatory support, and whenever like you are trying to wean them off, whenever you are trying to remove that oxygen from them but still they cannot maintain their oxygen level, we call that condition as bronchopulmonary dysplasia. Okay, what it shows is see uh, why we give oxygen to anyone in the hospitals. uh, Whenever patients come to the hospital, so uh, if their oxygen saturation is, for example, 99, 98, or 97, of course we don't give them oxygen. But someone who cannot maintain their oxygen level at that level at room air, okay, uh, in the hospital, so of course like we put them on oxygen. So of course like just so that they can maintain their oxygen. If someone or we can put them on ventilator as well. uh, for example, if you give oxygen to someone and now they're maintaining their oxygen at, for example, 95%, and once you remove the oxygen and you found that their oxygen saturation is again going down, down and down, it means like they are not ready to wean off from that ventilatory support or oxygen. So these are simply those babies, neonates who are require oxygen or ventilator support for more than 28 days. Okay. uh, Simply it could be like, of course there is damage to the lungs. Okay, uh, maybe due to prolonged intubation or ventilation or high levels of oxygen or infection, anything. Okay, so like the causes, you can say can be can be due to, okay, can be due to, you can say, developing, of course the lungs are developing, okay, developing lungs with prolonged uh, intubation, or you can say ventilation, okay, ventilation until intubation. I think you had a good concept about that. Or when we provide someone with high levels of oxygen, okay, or infection. So can be due to these causes, okay. Okay, so now see, the lung damage basically comes from many times it comes from the pressure and volume trauma from artificial ventilation, or oxygen have some toxic effects as well, if you don't know, like high levels of oxygen can cause different issues, okay. So how we find them? So see, the diagnosis is not like a one day diagnosis, but someone who is requiring oxygen or ventilation for more than 28 days. So it needs a long time, to diagnose this condition. We go for chest X-ray in these patients, okay, and the chest X-ray basically shows the signs of hyperinflation or inflammation or atelectasis. I know, like many of you are well, like know the terms, what these terms means, right? So I can show you the chest X-ray of a baby who have you can say this bronchopulmonary dysplasia, right? See, like in this X-ray, you can see that the lung is collapsed. See this one, okay, and like the lungs are over distended in this baby, of course, okay, and there is what you can say the signs of inflammation and hyperinflation. We can see the lungs are overinflated in this case. So, like this is how the lung X-ray looks like in these babies, right? Now, the condition is uh, of course lifelong, right? Because that's why it is also called as chronic lung disease. So in that X-ray you can see that there was opacification areas and some cystic changes as well, we can see. So of course, like when we cannot wean them off from the oxygen or ventilation, some of these infants, they need prolonged artificial ventilation and sometimes CPAP, continuous pressure, a positive airways pressure ventilation. So CPAP is needed sometimes as well. So of course, like if I will talk about the treatment, so you can say like there is no good treatment for these babies, okay. So our aim is to wean off from ventilator, of course, okay. Of course, like, and provide good nutrition. That is what you can do, okay. And one of the thing, what you can say, you can give a trial of dexamethasone, which is steroid, corticosteroid, okay. uh, but like of course, like corticosteroid therapy may help in early weaning off from the ventilator. Why? Because corticosteroids, what they do, uh, corticosteroids basically they decrease the inflammation, okay. This is from ventilator, okay. So corticosteroids basically they reduces the inflammation, and maybe like they will reduce the oxygen requirement as well because of reduced inflammation. uh, so we can try that, a short course of that can be given. So some of the babies, by the way, they can go home with some oxygen support at the home, okay. uh, can be given in cylinders, right? uh, Many of the babies they die as well because of pulmonary hypertension, especially the babies who get infection from any virus like respiratory syncytial virus, okay. So they can die as well of this condition. So like this is what you can say is called as bronchopulmonary dysplasia, and of course it's a chronic condition, and it stays with the baby, okay. So most of the babies, like many of the babies, they die even in good healthcare system. Many of the babies, they develop pulmonary hypertension, they show poor growth, they they go into cor pulmonary, or like right heart failure due to pulmonary conditions. Okay. um, and some of the babies, who have milder type of bronchopulmonary dysplasia, they may continue into uh, their adolescence. Okay, but like of course their lung functions keep on decreasing, and they develop a lot of complications later on. So this is like bronchopulmonary dysplasia. Then, like yeah, other than that, bronchopulmonary dysplasia, the other respiratory condition I will talk about is called as diaphragmatic hernia. Diaphragmatic hernia. Now, diaphragmatic hernia, like it's again a very interesting type of condition, you can say. Like as all of you know, what is hernia, right? Hernia is defined as when, what you can say, uh, like through any defect or any weak wall, and when the organs they protrude out uh, in some other cavity. Okay, for example, many of the people, they have abdominal hernia. So what happened, the intestines, they protrude out from the uh, you can say the weakness in the abdominal wall. Okay, so they come out from that weakness. Okay, so that is called as abdominal hernia. Inguinal hernia is there, umbilical hernias are there. So there are different type of hernias which can develop. What happens in, you can say, uh, in these babies is simply they have internal hernia, you can say diaphragmatic. Where is diaphragm? Okay, diaphragm is the separation between the chest cavity and the abdominal cavity. So what happens is these babies, they have diaphragmatic hernia, and the abdominal organs are basically in the thorax. Okay, so now a very what you can say, uh, common sense thing, guys, uh, like like where is the diaphragm? Okay, it is between the lungs and the abdominal cavity, right? um, so what happens is, when the abdominal contents will go into the chest through the diaphragm, the esophageal opening, they are going to compress the lungs. And when they are going to compress the lungs, what will happen? The babies cannot breathe properly. So you can say, by definition, uh, it's a developmental defect, right, of the diaphragm. PHRAGM, okay, of the diaphragm, with herniation of abdominal organs or contents, into the thorax, right? And now, like, think about that the abdominal contents are in the thorax, right? Because of that diaphragmatic opening. So the lungs will be compressed and the lungs will not expand properly. Okay. So what will happen, that now think logically. When the lungs cannot expand properly, so the babies will go into respiratory distress, right? And the babies may develop cyanosis. Okay, and the abdominal contents are now in thorax, so the abdomen will be, you can say, depressed, or we call it as scaphoid abdomen. Okay, the abdominal shape will be like, when you will examine the abdomen, you will find that the abdomen is a scaphoid abdomen. And now, as the contents of the abdomen is in the chest, so the chest will be prolonged, or barrel shaped chest will be there. Of course, like, this condition is associated with conditions like, pulmonary hypoplasia, like when the lungs are not well developed in many of the infants. So simply, uh, when the lungs are pushed away and the intestines are there, or the abdominal contents are there, the lungs will be pushed away on one side. So you will found, when you will percuss that area, so you will found dullness of percussion. and absent breath sounds. Okay, uh, is but like maybe you are going to hear vowel sounds in chest, because normally where there is lungs, basically now there is abdominal contents, right? The heart will be pushed away its uh, from its anatomical position, simply. Okay, so you are not going to hear the heart sounds at the place where we used to listen to the heart sounds. Okay, so this can be there. The chest movements, when you will observe, movements will be not be symmetric, rather asymmetric, right? Why? Because the chest movements cannot be normal, because the lungs are pushed on one side. So the chest movements will not be normal, and the trachea will be deviated from, like normally our trachea is in the middle, but as the lungs are pushed on one side, so the trachea will be pushed on one side as well. So the trachea is deviated away from the affected side, because of course the lungs are pushed from by the intestines to one side, so the trachea will be away from the affected sides. Okay, so simply trachea will be deviated. So you know why I found this condition very, very, very interesting. Okay, because of the treatment we provide in these babies. Okay, before going on that, we'll talk about the investigations. Okay, uh, basically whenever we get any a neonate with any anomaly, you can say, try to try to look for any other anomalies. Okay, anomalies. For example, this condition is associated with pulmonary hypoplasia, so try to examine their cardiovascular system, try to examine their neurological system, try to examine their all the other symptoms, just to systems other, just to like find out if they have any other abnormalities there or not, right? So uh, when you will do a chest x-ray, what you will found in these babies, right? See, when we are going to do a chest x-ray, we will not found the same photograph of chest which I show you there, but what we will found, bowel loops in the thorax, right? So now the intestinal loops are in the thorax. Okay, and usually they are on left side. Okay, and you know on the left side there is heart, so the heart is pushed away from its normal side. Okay, and the mediastinum will not look will not be like normal. Okay, rather it will be pushed away. Okay, you know I was telling you, like talking about, like the interesting thing is the treatment. Okay, now my question is here is what, like whenever for example we are going to find any infant with the signs of respiratory distress. For example, uh, you are having a patient or a baby, uh, and you found that the baby have cyanosis and breathing difficulties, and the baby is in respiratory distress. What is respiratory distress? You know, any baby who have like tachypnea, who have grunting sounds, who have abnormal chest movements, and who have cyanosis, of course we think like, the baby is in respiratory distress. Why? Because he cannot breathe properly. So what we do in these patients, simply we resuscitate, and we like try to, what you can say, provide them IV fluids and try to resuscitate them, try to do a CPR. And when we do CPR, what we do is like we like there is invasive methods or direct airways, in which like the air goes directly to the airways, but like how we do mouth to mouth breathing, or by the ambu bag, like we seal the ambu bag on the mouth and nose. Okay, so if you are going to give them what you can say, ventilation by ambu bag or by mouth to mouth breathing. So see, when we push the air inside the nose and the mouth, the air go into the lungs, as well as the air goes into the GIT as well. So if the air will go in their GIT, what will happen that the GIT will be full of air, or the intestines will be full of air, which will cause more air inside the intestines and more air inside the thorax. So that will basically make the condition of the patient worse than better. Why? Because you are pushing air both in lungs and GIT, and the air which is going in GIT is going to basically depress the lungs more and more, because right now the intestines are inside the thorax cavity. So remember, guys, the most important things, and that's why I found this condition interesting, is do not bag, mask, ventilate, because you are going to make the condition worse. Why? Because air will enter in the stomach and compress the lungs, right? So do not mask ventilate. Rather, what must be done? Immediate intubation. So you know what is intubation? I talk about this thing in the class already. Intubation is endotracheal intubation, in which what we do is like we put the endotracheal tube directly inside the trachea, right? So always intubate directly. Okay. And one more thing which we can do is like we can place a large bore orogastric tube to decompress, to release anything which is inside the intestines, to make it small in size, to decompress the bowel, right? So of course, like this is the most important thing. Okay. And of course, like the ultimate treatment for this thing is surgery. Okay. Surgery is needed, of course, to put the things back and repair that defect. So this is about diaphragmatic hernia. Very interesting and very important topic, right? After that, hypoglycemia. Uh, okay, hypoglycemia we are going to, I already covered, by the way, hypoglycemia in the previous lectures. Okay. Uh, what is there? Um, okay. What I will tell you in this lecture, because like I cannot include all these things in just one lecture. This lecture, we will talk about what is respiratory distress, but in the next lecture, we are going to talk about three very important conditions, very, very important condition in units. So, what is respiratory distress? Distress in the newborn. Okay. So in this lecture, we are going to discuss this thing, and in the next lecture, we are going to discuss the three very important conditions, very, very, very important conditions. Okay, which can occur in the newborns. Okay. So any baby, any newborn, any infant, any neonate, when they are born, okay, we see few things, and if those things are present, we say that the newborn is in respiratory depression or distress, right? So uh, the first thing, which is called as tachypnea. Okay, what is tachypnea in newborns? Respiratory rate greater than 60 per minute, right? Or one more thing can be tachycardia. Okay, of course, like what is tachycardia? When the heart rate is basically greater than 160 per minute, right? So tachypnea and tachycardia, like especially whenever tachypnea is there, the baby is breathing too fast. Okay, so we say that the baby is in respiratory distress. Not just this thing, rather if the baby is making any grunting sounds, okay? Grunting sounds, or you found on examination that there is subcostal or you could say intercostal in drawings, okay? Like in every language have a different, what you can say, word for these things in intercostal in drawings. Like in Urdu they say, pasliyan chal rahi hai, like this, So every language have its own words, local language, right? And one thing is nasal flaring, like their nares they flare when they try to breathe in. Okay, so nasal flaring is there. There could be cyanosis, okay, which is central, of course. Peripheral one depends more on the temperature and things like this. Central cyanosis means like the oxygenation level of the blood is really less, right? That's why that is there. Or you can say the duskiness, okay? The skin color is dusky. Duskiness is there. Duskiness, okay, can be there. And on examination, if you found like there is decreased air entry and crackles on auscultation. Okay, so whenever we found any one of these clinical features, we say that the baby is in respiratory depression, or respiratory distress. Okay, simply respiratory distress, or like the child is, of course, having some sort of issue for that, the breathing or the respiration is not working fine. Now, what are the causes? Like, of course, whenever, like, this is the clinical diagnosis, right? You went to a ward and you see a baby who have tachypnea, tachycardia, grunting sound, cyanosis, and decreased air entry. Now you will start thinking about what are the causes. Okay, so what are the causes of respiratory? By the way, like the causes are, I think, too much, so I will continue that thing in the next slide instead. Okay, so causes of respiratory distress in newborn. So one of the thing, which is the causes, like first for sure, like the first one should be pulmonary causes. Okay, so pulmonary causes are there. You can say infections can be one of the cause. Cardiac causes can be there. Okay, as well as hematological causes can be there. Um, Anatomical abnormalities can be there. Metabolic causes can be there. Okay, metabolic causes can be there, as well as neurological causes can be there, right? So there are different causes of respiratory depression in the newborns, you can say. So whenever like we are dealing with any newborn, okay, and they have respiratory depression, so we have to think on these lines. Okay, so if we will talk about the pulmonary causes, one of the thing is respiratory distress syndrome, a very, very, very important topic which we will discuss in the next lecture. One cause can be transient tachypnea of newborn. Okay, again, a very, very, very important topic. And the third cause is meconium aspiration syndrome. And now, these three causes we are going to discuss in the next lecture. Okay, so in the next lecture we'll be discussing about respiratory distress syndrome. We'll discuss about transient tachypnea of newborn. We will discuss about meconium aspiration syndrome. Okay, so other causes which are quite common, and many of them you know already. It could be pleural effusion. Okay, effusion. It could be pleural effusion, it could be pneumothorax. Okay, all these things can be birth injuries and can be managed. Okay, or there can be congenital malformations simply. Okay, congenital malformations can be there. Uh, when we'll talk about infections, guys, the most common infection, sepsis, which I will try to talk a little about in the next lecture, or it could be pneumonia. Okay, so see, pneumonia or if sepsis, of course, they can lead to respiratory depression. Okay, so cardiac causes, the most common should be congenital heart diseases. It could be cyanotic, it could be acyanotic, or I think this one is the most common causes, okay, which you must think of in the newborn. The hematological causes can be either anemia or blood loss, okay, or it could be like too much red blood cells or polycythemia, which can lead to what you can say respiratory distress in newborn. Anatomical causes, again, they are mostly congenital disorders like tracheoesophageal fistula, okay, tracheoesophageal fistula, or just now we studied one condition which is anatomical defect, congenital diaphragmatic hernia, right? So see, this is one of the cause. Um then there can be anything which is causing atelectasis like mucus plug, okay, can be there, which is causing atelectasis, or any type of airway obstruction by anything, okay. Then there are metabolic causes, guys. Again, it could be hypoglycemia. Remember, hypoglycemia can lead to respiratory distress, or inborn errors of metabolism. I I don't know when this lecture will come, but I'm sure like now you heard this term a lot of time, but they are very easy and they are not so important, all of them. Just few of them, they are important. We are going to talk about that. Neurological damage could be there, or neurological abnormality can be there. For example, CNS damage can be done by birth trauma, by hemorrhage, intraventricular hemorrhage, or intracranial hemorrhage, which we have already covered about. Or it could be drugs, or the effect of drugs which is causing respiratory distress, right? So these are all the causes of respiratory distress in the newborn. So now the last thing which we are going to discuss today, and then we will talk about this thing in the next lectures, is how we investigate anyone, what you can say, who in which like there is respiratory distress. So you can see like there is pulmonary causes, there is non-pulmonary causes, or you can say there is pulmonary causes, there is in non-pulmonary causes there is cardiac causes, metabolic causes, hematological causes, as well as anatomical causes, and all this ones, right? So we can simply divide them into pulmonary or non-pulmonary, or we can simply divide into different categories. So the most common pulmonary cause is transient tachypnea of newborn, which is by the name shows transient, which is a short-lived condition and it goes away by itself. Okay, this is the most common one, right? So whenever the babies are born and they have like they are in respiratory distress, you must think about transient tachypnea of newborn. It is the most common one. Less common conditions can be meconium aspiration, can be pneumonia, can be respiratory distress, can be pneumothorax, okay, can be persistent pulmonary hypertension or bronchopulmonary dysplasia. It could be milk aspiration even, okay, and very rare causes you can say are basically diaphragmatic hernia, or tracheoesophageal fistula, or pulmonary hypoplasia, or for example airway obstruction, okay. And non-pulmonary causes, congenital heart diseases should come into the mind, the first one. Then think about birth trauma, think about severe anemia, think about metabolic acidosis, so on and so forth. Like this is how we must go, okay, how we must approach the patients, right? So what we do, like all the affected infants should be we always go and admit to the hospital, okay, and we monitor their heart rate, we monitor their respiratory rate, we monitor their oxygen saturations, We take a chest x-ray. Of course, the first investigation of choice is chest x-ray. Okay, we go for chest x-ray. Like, of course, it is going to give you a lot of content. See, if you will do chest x-ray, what things you can catch? You can catch pneumonia, you can catch pneumothorax, you can catch pleural effusion, you can catch bronchopulmonary not sorry, you can catch subdiaphragmatic hernia. So see, chest x-ray is a very, very, very important investigation, and it is required. It helps you to identify the cause. Okay, especially those causes, you know, in which you can do something immediate, like pneumothorax or diaphragmatic hernia, for example. Okay, so what I told you is, like, we are searching for the cause, and chest x-ray is such a nice investigation that it can tell you, or it can help you in identifying the cause, especially the cause which you can give some immediate management or treatment, and the condition can be treated. For example, pneumothorax, I told you. For example, diaphragmatic hernia, I told you. Okay, we also other investigations which can be done is atrial blood gases, of course. Okay, very important. Again, it will tell you a lot of conditions. It will tell you either there is acidosis, it will tell you what is the saturation of oxygen, how much is the carbon dioxide level, and all those things, right? uh, Other investigations which can be done is, of course, you can go for CBC, you can go for ESR, CRP. Okay, you can go for blood cultures to check for infections. You can check the blood glucose levels, of course, because hypoglycemia is one of the cause. We can go for ECG. We can go for echocardiography. Okay, so what we are doing is basically we are finding out the cause, right? So chest X-ray, right? Sepsis we had done. Okay, congenital heart defects we can done echo. CBC can tell you this thing. Chest X-ray can tell you this thing. Chest X-ray can tell you this thing. Chest X-ray. Glucose levels are there. And CNS damage of drugs. Okay, this one can be checked on the history as well as on the examination, and drugs again on the history. So one more thing we will add, and I think we will finish all the investigations. You can say metabolic screening can be done. If, of course, like I'm telling you, this is when we talk about investigation, guys, we have to discuss everything, but in reality we go more sensibly. We don't put anyone in too much investigations we don't, which are not helpful or which the patients they don't need. Okay, so we think logically. So that's about what you can say, what is respiratory distress syndrome. And in the next lecture, what we are going to discuss is we will discuss respiratory distress syndrome. We will discuss transient tachypnea of the newborn. We will discuss meconium aspiration syndrome. And in the same lecture, if we had time, we will talk about sepsis. Okay, and then we will move on to the next topics. Okay, rest of the topics of neonates. So that's all for today. Uh, okay, so in this lecture, by the way, the important things like we had covered. I show you the X-ray of this one, right? I show you the X-ray of this one. You can check an X-ray of diaphragmatic hernia. Okay, and a very good practice would be, like, if you will try to see as many as chest X-rays which you can, and try to learn how to interpret chest X-rays. Okay, it will be a good practice. I'm not talking about pediatrics. I'm talking about, like, you can check even the adult X-rays. Okay, online, Google, or from your radiology books. Okay, because how to interpret chest X-rays and how to see that. So hope so, like, you guys understand these topics, and like next week we are going to talk about meconium aspiration syndrome, and all this stuff. And we are going to finish the common conditions of the neonates in the next lecture. So thank you so much, guys, for listening.